All right, and welcome to everyone. I think we'll wait a couple of minutes just for some people to enter as we just started, but I'm looking forward to this talk because I've been trying to do some MR imaging at the sim, and
I'm happy to share my tricks and
right, I quite seriously was when I read your talk, I was like, ooh, perfect.
Yeah, hopefully we'll have time at the end to discuss because it has been challenging.
Mm-hmm. Wow, I just noticed it's snowing outside. What are we? April 27th. All right. I'll wait one more minute and then we'll get started. Okay, so thanks everyone for joining. It gives me great pleasure to introduce our speaker today. Her name's Mary Brossard-Racine, Dr. Mary Brossard-Racine. She's an occupational therapist and she's a tenured associate professor in the School of Physical and Occupational Therapy here at McGill. She has appointments in the Division of Neonatology at the Children's and is a scientist at the RI. She's also a Canadian Research Chair in Brain and Child Development, and her research is investigating the mechanisms of function and dysfunction in children with neurodevelopmental disorders. Just looking at her research program or her research approach, it's very similar to mine, except I look at the lungs and she looks at the brain. So I'm really looking forward to this. So yeah, take it away.
Thank you, Ben. Well, thank you for having me and thank you for this opportunity to share my work. Today I will, sorry, let me just organize my slide a little bit better. So today, the outline of the presentation, well, first I will give you a brief story of the research MRI that has been performed at the Montreal Children's Hospital as part of the RI-MUHC. I will also discuss briefly, our mission or our goal at the ABCD Research Lab, share some of our success story, but also I will definitively save time to talk about the current challenges and limitations we're facing using the platform as it is currently, and how maybe we can also see potential value for future success. So historically, it's only been, if I understood correctly, because to a disclaimer, I only joined the RI and UHC community in 2015. So I think around 2010, when at the MUHC, when it was on Atwater, there was some type of agreement that was decided to share the magnet in neurology, the magnet that's being used for neurosurgery, between obviously neurosurgery, but also clinic and to save sometimes to be used for research. But it's only in 2012 that we had a first agreement with Philips Healthcare, where this actually involved collaborating with a physicist at healthcare, so that then that could help implementing research protocol, and also developing of sequence. And it's really, to my understanding, it's really Pia Wintermark around that time, 2012, who was the first clinician researcher which pediatric MRI was really like a center, an important part of her research program, where that was one of the main outcome, being measures, in critically ill neonates. And historically, my understanding also is that, people doing research MRI were mostly physicians capitalizing on already prescribed clinical MRI as part of standard of care. So either adding a few sequences, but there was no real structure where researchers that were not MDs or neuroradiologists or studying a population, that did not have to undergo a prescribed clinically MRI. There was no real path, for those researchers. And I am aware that one researcher, Isabelle Gagnon, I know at the old installation, that who was able to get to collect some type of data. I think as part of a study in collaboration with the Neuro, they were able to scan about like 40 patients over 2 years. So, very little access overall, but still, this was really the beginning of research. So there was kind of like two paths, one for physician capitalizing on already prescribed clinical exam, and some type of a new path for pure research, for pure research MRI only. But again, like only using the clinical resources. So, it was really an understanding. So it was the clinical technologists, MRI technologists, helping out, the research. Then in 2015, we moved to the Glen. This is also where I came in. And, we really benefit from the strong leadership of Bruce Mazer, like making this platform, happening when he was having a leadership role, with the CHHD and the RI-MUHC, who really helped, developing further that pure research path. And we had a collaborative grant, me, myself, Daniel, Pia Wintermark, and other neuropediatric researcher who facilitate kind of like that implementation to support the salary of MRI technologists that would be hired only for research MRI. And it's with the help of the SIM that in 2016, we started to really to develop a system where we would be able to book the MRI with an MRI, with a research MRI technologist, outside of clinical hours when the magnet was not being used by neurosurgery for outpatient, to actually scan patient that didn't have to go undergo a clinical MRI at that time. So, and that's what we've been working on. Working with, for the past 6 years. And our research agreement was renewed in 2021. So that's just like the snapshot of the history, part of what I understood, part of what I know since I've been here 2015, and part and the pieces that I put together for what was here before. And so at the ABCD Research Lab that I started as I joined McGill in 2015, our overall mission is really to support all children to thrive and develop to their full potential. And I guess what's maybe a bit different than other research labs is that we're not necessarily focusing on, we don't really have a diagnosis approach, but we're really focusing on function. So we're looking at children, yes, with a confirmed brain-based disorders such as cerebral palsy, ADHD, ASD in general, but we're also following at-risk children, children with an at-risk condition, but without a formal diagnosis. And our approach is interdisciplinary. So we're combining, obviously, the brain MRI techniques, but with a focus on quantitative methodology with clinical relevant evaluation and intervention. And our goal is to search for biomarkers of dysfunction, but also that could maybe help, measure our intervention effectiveness, and eventually, that will help us understand what can enhance brain recovery and support child healthy development. So I'm just going to dive in one of our first, actually the first imaging study I initiated as soon after we were able to launch the platform, which really aimed to characterize brain development and function in children with an at-risk condition. So for technical reason, although, for those who know me a bit more, like they know that I've been working with younger kids for many technical reasons that I'm not going to go into, we started looking by studying the brain and the function in adolescent and young adult, either born preterm or with the congenital heart defect, and compare their brain and function to healthy control. And today, the focus of this talk will really be on our result from the CHD group. So what is CHD? Well, CHD is an umbrella term that refers to any structural anomaly of the heart or its vessel. And it encompasses actually more than 18 types of CHD. And with the prevalence of 1%, it's the most common neonatal malformation. About a quarter of those are considered critical, meaning that they will require an open heart surgery using cardiopulmonary bypass during infancy to survive. And with the advance of the surgical and overall care for these children, now 20 years later, the number of living adults now outnumbers the number of children. And with this reduction of mortality, we have been observing an increased risk in mortality rate. And up to 70% of neurodevelopmental deficits have been reported in this population, and these will affect the motor skills, the cognition, like some portion will present with cognitive impairment. But what has been more frequently reported in the last decade, as these children are getting older, and is that they have poor executive function. So it's also like really the higher order cognitive processes that are affected. Also, more recently, there is a greater underappreciation of their emotional difficulties. And overall, so for those who might not know this population, so these are not necessarily the children or the young adult, that will be picked up in the classroom as having like major difficulties. But overall, when we look at their trajectories, they seem to have a bumpier road and been struggling at certain transition point in their life. And it is now known that they also have lower academic achievement and employment rate during adulthood. Like many other neurodevelopmental disorder, there's no early predictor for later dysfunction. And actually, their neurodevelopmental deficit has been described to be plastic, meaning that they can be absent during early infancy, appear later on during childhood, or only during adolescent and young adulthood. And because of our inability to predict later outcome, the American Heart Association has published a strong statement recommendation for practice, urging that individuals with CHD receive frequent and periodic follow-up during infancy, childhood, but also adolescence and adulthood. Obviously, American Association recommendation and our Canadian healthcare system is not necessarily aligned. And actually, that was the work of one of my PhD students, Marie-Ève Bolduc, who's just finishing her PhD, who just handed her thesis. And so what she did, she performed a national environmental scan to identify what were the current follow-up practice for these children in Canada. So she contacted the 8 tertiary care centers that perform open heart surgery in the country to really understand what were the current follow-up practice and surveillance, including surveillance for these kids. And what the study highlights is that only a subset of those centers, so about half of the center, identify having a systematic developmental follow-up program in place, but often these developmental follow-up programs were really limited to the very most critically ill children. So, for example, the children having really the most severe condition, and were limited the developmental services were limited to infancy and the preschool year, so not capturing what has been recommended by the American Heart Association, to assess during school age year, adolescence, and even adulthood. So what our study is concluding is that current practice may fail to promptly identify children and adolescents who are experiencing challenges. And also what has likely complicated, like the implementation of clear guideline is that the etiology of their developmental deficits remains unclear. But what has been well established over the past 15 to 20 years is that acquired brain injury in neonates, in neonates with CHD, is a major and frequent complication. So these children, like when they're imaged within the first few days of life, even before they undergo their surgery, there's about 40% of brain lesion that are reported in the contemporary cohort. And it's actually about 20 years ago now that Dr. Miller and collaborators who identify the resembling pattern of the injury observed in the term-born CHD to mimic the type of injury also observed in the preterm brain, and which are the white matter injury which are the small punctate injury of the white matter. So basically what I'm trying to say is that, so even if these babies were born at term, their brain were kind of immature and showing frequently injury pattern that are mimicking injury seen in a 32-weeker or preterm born neonate, even though they were born at term. And this suggests, sorry, I went too fast. So this suggests that there is an inherent condition, so that even even though they're born at term, there is something happening in the womb, indicating that the brain is not fully developing like a term. And as I conducted my postdoctoral work in Washington, D.C. with Catherine Lamperopoulos, who was really pioneer in identifying and characterizing using MRI the distress of the brain of these fetuses with CHD. We so we looked at the MRI, the brain MRI of 144 fetuses with CHD and almost 200 healthy control scanned image during the second and the third trimester. And what we observe is that almost a quarter of the CHD children presented with brain anomaly already detected on MRI during the second or the third trimester. And this is the type of, so the abnormality that we saw at that time were less impressive than the bleed or the microbleed that could be observed during the neonatal period. But what they look like, so in the top images, you have the axial view of a healthy 32-weeker, and on the bottom, 32-weeker with CHD, showing unilateral ventriculomegaly. And another common anomaly that we observed was intracranial, so increased intracranial space, so more CSF around the brain. So same thing here, you have like the picture of a 27-weeker healthy control, and under the CHD of the same age, and you can see, there's like increased CSF around the brain within the same intracranial, within the same intracranial space. And so what we understood from all these reports is that even if they vary in presentation overall, I'm just presenting the two most common, all the anomalies report were in fact considered marker of delayed brain development. So this was really the first study using clinical MRI to characterize and identify the high range of brain anomaly in children with CHD. And subsequently, we provided the first report establishing the direct link between fetal and postnatal brain dysmaturation, where we identified that CHD with abnormal fetal brain MRI had 90% more chance of presenting with an abnormal neonatal brain. So really connecting, so this inherent condition of dysmaturation that's starting in utero put at greater risk for neonatal injury within the perioperative period. And unfortunately, the story doesn't end there. You know, there has been like other reports showing that these children are also at greater risk for additional post-operative injury. So even though some may or may not have had injury before the surgery, something's happening between or during or after the post-surgical period. New bleeds, hemorrhage, infarct are being reported. And when we image those children, you know, at 3 to 6 months later, or 3 to 6 months of age, if they had like a surgery during the first few weeks of life, some resolution of the malwater, the white matter injury were observed, but persisting, you know, lesion and cerebral atrophy was observed in many cases, and this increased CSF and increase and decrease atrophy or increased atrophy of the brain was also observable, you know, at 2 years of age. And subsequently, again, with Marie-Ève Bolduc, you know, we conducted a systematic review and meta-analysis and calculated that youth with CHD, so like that's 20 years later, or 15 to 20 years after their surgery, children or adolescents with CHD were almost 16 times more likely than control to present with brain anomaly, likely lesion of early life, of likely injuring lesion of early life dysfunction, of early life injury. So just to recap briefly, so the previous focus of research has really been early detection of brain injury, trying to find prevention or associated risk factors. I know there's a few centers currently ongoing looking at neuroprotective strategies, maybe fetal interventions such as motor hyperoxygenation to try to really help the brain to mature, you know, during the womb and limit this impact of on brain development later on. But there's really been little attention about what happened after discharge, and if the brain catch up at some point, or what are or if these enduring lesions that we're trying to see on conventional MRI could really be associated with outcome, and if so, what can we do to optimize outcome? So this was the rationale for the first study that I started with my startup fund, you know, at the beginning, and then we were lucky to get some some other small fund to continue that study. And the major aims for our study was really to characterize the nature of the brain alteration that could still be seen in youth with CHD, using this time quantitative MRI. So and I'll get into more detail a bit later about what the difference between conventional and quantitative, but also we wanted to further describe the nature of the brain dysmaturation syndromes present in the individual with CHD, and obviously evaluate structure-function relationship. So we concluded the enrollment last year. So between 2016 and 21, we recruited 62 youth with CHD who were operated before 2 years of age. We recruited children between 16 and 24 years old. We also, you know, so participants came to the Montreal Children to complete one study visit where they would undergo a brain MRI, but also where they would, we would measure, have a brief evaluation of IQ, complete several questionnaires to have an understanding of their executive functioning, and also also better understand their psychological psycho-emotional well-being. And I guess like a first limitation that I'm going to put out there is that because this was conduct with my startup fund, I really capitalized on getting the most images that could be. So all my money went in the MRI, and we didn't perform like extensive battery of cognitive ability, which I wish we did, but you need to choose where you're putting your money on. And so as control group, we were fortunate to recruit a match control group matched by sex and age from the community. And we also now have another comparison group of youth that were born very preterm. But I'm not going to go into detail, but I'm just showcasing this because I have a great student who's actually tackling this data. So to be present soon. So using quantitative MRI processes, so using quantitative MRI, and I guess like the distinction between conventional and qualitative MRI. Conventional MRI refers to what we get from clinical prescription of an MRI. So this is being visually eyeballed by experienced neuroradiologists, who will be able to comment, on the presence of lesion, dysmaturation, malformation, and many other critical aspects of this. The quantitative aspect is when we're able to apply sophisticated pipeline to really pre-process the images and extract some quantitative and some quantitative matrix to measure different aspect of the structural or functional integrity. And I lost my train of thought, but I guess that the difference is really the quantitative aspect is like, I guess, yes, that's right. So from those quantitative matrix, what we hope is to be able to detect more subtle brain variation and more reliably that could be missed by visual inspection. So using quantitative MRI processing pipeline, one of my first master's student was able to segment, so segment the hippocampus, which is an interesting region in itself because it's been involved in many higher order cognitive processes. And so we were able to extract the volume of the hippocampus itself, but also we were able to segment the hippocampus in subsection, all known to have some functional specificity, as well as extracting surface area to look at the morphometry. So not only the volume, but to look at the shape to, for example, because we infer that maybe if the hippocampus is alterated, maybe like the shape of the hippocampus would be different, with development. So we're trying to use quantitative marker to describe this. And so she compares CHD adolescent and young adult to healthy match for sex healthy match sex and age control. And what she found is that overall youth with CHD had significantly smaller total hippocampal volume, as well as it all is subregion. And CHD also had a smaller surface area and inward displacement, especially in the left hippocampus, with a deformation concentrated to the ventral region of the hippocampus. And what's interesting is that the ventral area is thought to be involved in management of stress and emotional and affect. So we thought that was very interesting. But what was actually more interesting, particularly interesting from Kim's work, is that, so when looking at the subfield of the hippocampus as a subdivision of the volume of those subdivision, she was able to find that working memory as measured on our executive function measure was in fact associated with smaller, so worse working memory was associated with smaller cornus ammonis 1 and 2 and 3. So these are two small regions of the hippocampus, of the left hippocampus, that was associated with working memory. And what was particularly interesting is that this association was not present in the control. and would have been missed, just by visual inspection or by performing like simple correlation with total like hippocampus and cognition. So really like reinforcing the need of like, we need to look, to look more precisely and to look at smaller differences, in this population. And recently, we also look at the functional connectivity of different several networks actually known to also be involved with executive function. And we find different pattern of connectivity between the CHD and the control, some of lower and some of increased functional activity, but overall different, between always different than the control. And what we found is that, again, we found different association between connectivity in the CHD than in the control. So for instance, in the CHD group, we found correlation between the right frontal orbital and left hippocampus functional connectivity and performance on the inhibition subscales of our executive function measure. And conversely, in the control group, the significant association were found between the connectivity between the intraparietal sulcus and the right hippocampus and the emotional control scales. So again, definitively, there's something happening with the hippocampus that's different in the CHD than in the control, and that seems to be related to the processing of higher cognitive function. Obviously, this is important. It's important to keep in mind that these specific brain abnormalities that I've described today are part of a bigger portrait of overall brain differences that we're still trying to determine the fingerprint. But like I said, what's interesting is that using established quantitative MRI technique, we were able to find structural and functional alteration of the hippocampus that are associated with executive function. And of note, because we're not performing systematic follow-up of youth with CHD, psychosocial and executive function is not currently systematically screened in clinic. Sorry, I went too fast. Another important component of our work in our lab is also to test novel quantitative MRI techniques or our method in clinical population, and to explore a novel potential marker of microstructure that could perhaps give us more information about the nature of the white matter alteration that have been systematically described in this cohort. One of my PhD students, Caitlin, is actually looking at these at a couple of new quantitative MRI technique. So the first one I'm going to present today is her work that she's done using neurite orientation, dispersion, and density imaging, which is a type of multi-shell diffusion acquisition. So using, again, like sophisticated pipeline, she was able to extract 33, so she was able to extract node matrix, which I'm going to go more in detail in a second, in 33 white matter bundle, well recognized, anatomically well recognized in the brain. So these encompass the association tracks that are known to be associated with higher order cognitive processing, the projection tracks, which involve, the corona radia, the cortical spinal tract, so more kind of like the sensory motor tracts, the cerebral motor tract, and the commissural tracts, which is basically subdivision of the corpus callosum. So within these tracts, Caitlin measured two specific markers, so neurite density index, which can be seen as a marker, a surrogate for the number of axons within a bundle, and as well as orientation dispersion index, which is a marker of the dispersion and coherence of these axons within that bundle. And what she found was that neurite density index was significantly lower in many regions, mostly the body of the corpus callosum, but in many association tracts, like I said, known to be involved with higher order cognitive processes. However, she did not found significant difference in orientation dispersion index. So it seems that the white matter, the enduring white matter anomaly detected in the CHD samples could be related to a lower number of axon packing, but not to a difference in axonal organization and orientation. And I guess the subsequent question that we had was that is that lower density or axonal packing represent a direct axonal loss, or since diffusion is kind of like an indirect measure of many neurobiological and cellular processes undergoing in the brain, could also be driven by a myelin loss, which is one of the hypotheses of the early life neonatal brain injury. So more recently, she just published this subsequent work where she used another quantitative MRI matrix acquisition called MC-DESPOT, which is thought to be a more specific technique to measure brain myelination. And what she found is that lower myelination was observed in many association track again, but this time also in the projection track, and as well as in all the subdivision of the corpus callosum. And this further confirmed that brain dysmaturation in this population will persist into early adulthood. And Kathleen is currently, she's been very productive, and she's currently investigating further the relationship between all these novel metrics to really inform on the complex nature of these observed white matter abnormality, but also investigating their relationship with function. I'm out of practice. I haven't presented in a while, and I'm 2 weeks post-COVID, so I think I'm out of breath. So this was a quick summary of what we've done. In adolescent, like I said, I really presented a snapshot. We actually, when these patients are coming, to get their brain MRI, they're undergoing multimodal MRI. And we actually have more sequence, we have more data than we have manpower to analyze this. But overall, we're really satisfied with we're really thrilled by what it's been showing. But in parallel, I guess the other study that I want to present is that we're doing a parallel study. So in this same group, as the youth, we are also conducting a longitudinal study of preterm CHD and LT control during the first 2 years of life. So we receive we call this study the unicorn study, and we receive first funding from the Department of Defense to support the CHD cohort, and later on from CIHR to support the preterm cohort. And what we've been seeing, what we've been doing actually, so we're recruiting these patients post-discharge, so after their cardiac surgery, and are asking them to come for a study visit, ideally every 3 months. The reality is that this has been quite overwhelming in addition to their clinical appointment, especially for the cardiac patient, who often have like cardiology appointment and so on. But, this would be like we're offering the Lamborghini, and then the parents decide what's possible, and we take we take where they are able to offer. So we're asking the parents to come for brain research MRI, as well as extensive developmental testing, and we're also collecting information on parental stress and competency at different strategic time points. And the goal of this study really is that, knowing that the first 2 years of life is one of the most critical in terms of brain development, where most of the neuroplasticity is happening. We want to characterize the growth trajectory using some of the markers that we've tested in our adolescent study. And we want to assess the growth trajectory within the first year that follows the open heart surgery. And what we hope to see is that, we might be able to identify typical versus we might be able to tease out, which children will show a typical trajectory from the typical one, and maybe identify a critical period for early stimulation. So these are our research participants, obviously 3 different children, but, coming for their study visit, at 6 months, 15 months, 18 months. So first we're trying to exhaust them, because what's coming next is that we're performing non-sedated MRI. So these are non-sedated. These are MRI performed under natural sleep. So obviously, this requires like a lot of technical skills from our coordination team and working closely with the MRI technologists, but and it's been quite challenging, but when it works, you can see we can obtain very nice images of the brain. And this is the work, ongoing work of Ellie Ite, who's a finishing master's student. And so what she did is that in this time, we were not able to apply sophisticated pre-existing pipeline, because these are often, the MRI processing pipeline are often only available for the adult brain, because they are different in size, but also in contrast and in water content. So she manually segmented the hippocampus of these babies with CHD that you can see in blue, as well as in a control group of healthy term-born infant that you can see in orange. And well, you can see by yourself that between 1.5 and 18 months, although, we do need more data to confirm those trajectories, but although they have like similar trajectories, like the hippocampal volume of the individual with CHD seems to be lower and dragging in terms of growth, yes. And also, I have Sarah, Dr. Sarah Palmi, who's a PhD postdoctoral fellow in the lab, and she's particularly interested in looking at the cerebellar development of our babies, so in the preterm, but also in the CHD. And similarly, although this region of the brain is showing a different growth trajectories than the hippocampus, you can still see that the CHD volume of the cerebellum is quite lower, is lower to some extent than the control. However, there seems to be like a catch-up period, like around 1 year of age. But again, we need to get more data to confirm this. And I'm sure you can imagine how dramatic COVID and the repetitive shutdown and wave has been on those longitudinal studies. But, we're continuing to collect data. Okay, so I've presented some success, so maybe you're asking, well, what are the problems with the MR platform, right? Because obviously, and it was great for me, the opportunity to put this together, because like I said, I haven't presented this data before. So last time it was before my last maternity leave, so it was great to really see and reflect on what we've been able to do, during this past, even with COVID affecting all of us. But what I have not presented is the monstrous heavy lifting that is requiring and deployed for every successful MRI, and the number of trial, the number of appointment cancellation, and I haven't talked about like the entire study that didn't happen at all or failed because of our inability to really reliably access the MRI or complete these exams. So I'm really going to take the next couple of minutes to walk you through the current challenges, and hopefully we'll still have time to discuss potential opportunity for the future. So the first problem is really the accessibility, because like I maybe I actually explain how it works at how it used to work at the other children, but since we've moved to the gland, we have access to the MRI when it's not being used by neurosurgery. So this is typically the Tuesday and the Friday, as well as the weekend. However, since also this MRI is absorbing some of the overflow of the clinic, we haven't been able to access the MRI on Tuesdays and Friday before 3 p.m. And when we did, this has resulted in a high rate of last minute cancellation because they had an emergency patient to scan. And this has been quite inconvenient for outpatients, who try to coordinate their study visit, with clinical appointment to minimize displacement and discomfort of the family, especially with the small babies when they want to try to time, their MRI around nap time when we're performing those under natural sleep. But also that what has been more frustrating is really our inability to respect the research protocol. And although for the study that I've presented today, timing of the MRI, it might not be so critical because these are outpatient, we have some flexibility about scheduling those MRI. I would say talk to Dr. Wintermark, who has to scan her babies, on day of life 1 and then 5, or to follow like a specific protocol, or similarly a project that me and Dr. Gagnon conduct together, where we had to scan patient following a concussion within the 24 or 48 hours of the impact. Well, if your patient has their concussion on the Wednesday, you're unable to capture that study visit. So that has been definitively quite frustrating. And obviously, the schedule that we're offering is not attractive, to retain and hire high qualified personnel. Because of these unreliable schedule, so far we've been offering part-time and often only on-call position. So on-call position. So this means that right now we're very lucky to have MRI technologists who, in addition to their full-time job, agree to come in, during the evening or on the weekends. But however, you can imagine that it's not sustainable to offer that type of schedule, like on a weekly basis. And similarly, outside technologists that we definitively need, it's also unappealing to the research coordinators or even the student, to offer this type of schedule, on a weekly basis. And MRI, it's a unique environment, like everything, it requires like specific trainings. Like it's not whoever who wants to go within the MRI and then that has the knowledge of assisting with the preparation to undergo a non-sedated MRI. So that definitively required training, and you want to have as less people involved going in and out of this secure environment to maximize safety of the patient. And overall, the current MRI environment is really not conducive of non-sedated pediatric research. So the use of sedation is known, so I'm talking from a neuroscience point of view, that the use of sedation is known to have a negative effect on brain development. So obviously, like, I'm not going to sedate my patient, my participant, to participate to a research scan. So it needs to be a really supportive environment where the family, the children are going to feel safe, where we have some type of control on the environment to put some baby to sleep. A newborn or a 3-month-old might be able to sleep wherever, but try to put a 12-month-old to sleep in a clinical environment. It might be more difficult. And I guess I'm gonna walk you through the pediatric research environment to give you a better idea, because I think like images are more will or can say with my words, but what I would like you to just take a few seconds before we dive in is that put yourself into the shoes of a mom coming or a dad coming with their kid for a purely volunteer research study with their baby, at night, where you're going to perform like a sleep study, or picture yourself as a 7-year-old kid with some type of neurodevelopmental disorder who agreed to participate to a research study, part of it because we were able to sell it to you that it was going to be fun, but also because you want to help, so you're happy to be there. So you come to your appointment and you get at the 3rd floor of the A building in the Montreal Children, and you enter the daily surgery area. So it's a hospital. It's nice. There is a paw on the floor. It's appealing. There's like some decal. Then you get into the hallway and you're following those, but which is fine. But whoops, at some steps, there's no more pod. There's no more decal. And then you have to go through this big door. And on the other side, it's a hall with stretchers, bench, storage. There's nothing kids friendly anymore. Sorry, we're going the other way around. Sorry. Yes, sorry. And then you get to the MRI room, which is another dark door with like warning sign on it. Like you have to move, if you have like a stroller, you have to get there, move around the table and all the chairs that's everywhere in the hall. And you open this door, and what is this? It's another storage room, with a bunch of equipment. There's absolutely nothing friendly here. And this is just another view of that room. So imagine that we need to put babies to sleep in this environment. And this is the first room where we actually have control over the lights, because before we were trying to put the baby to sleep in another room outside and bring the asleep baby in the hall with all the light. But you can see behind the door, there's still lights getting in. So again, even if it's like 10 p.m. at night and we're trying to do those sleep studies, there's still light getting in. And the only intimacy you have is this little curtain that's going to separate you from the clinical team, the research team. So if you have to breastfeed your baby or put them to sleep, I'm sure you can imagine how little privacy you have here. And again, I talked about the light, but also we have no control about when maintenance is going to decide to pass the vacuum or the cleaning the floor behind the door. So I'm sure you can imagine how this has been quite impressive that we've been able to collect that many MRI considering that environment. And this is our magnet, pretty standard, pretty clinical, just very, very sterile and not very kids friendly. So, well, you may think, well, this is a clinical research, we're dealing with a clinical reality, we're in an environment, this is the research reality. Yes, but let me just show you what other clinical MRI facility looks like some places. So this is, like in the Northport Medical Center, so not even like a research facility, like a clinical one. And there are many examples if you Google, like pediatric MRI, different teams, space, C, so on. And obviously this is really sophisticated, but it doesn't have to be. This is an example of my collaborator at Brown University who are simply hanging big panel that they've made, to make the theme a bit more appealing. This is obviously not for the baby. This is for the school age kids, but so we have like the research staff is dressed like people working at the NASA, so they're going into a spaceship, and they're really simply hanging, like this panel in front of their very sterile MRI. However, because we're using the neurosurgical magnet, and because of disease infection protection, obviously we are much more limited in terms of like what we could put into place with this magnet. So I think you will all agree that there is like an urgent call for action. Like I think I've demonstrated that obviously we are able to perform pure research MRI in specific population, like an older outpatient with maybe a greater understanding of what's going on, with no severe cognitive deficits, like like my adolescent study, we have had like some great success, but definitively the current platform is limiting us to grow further. And we're going to have to decide, as a community, what's going to be the next step. But like I said, I think this is really an opportunity for us to grow as a community, the clinic, but also the research. So for example, like the high usage of sedation, there are many centers across the world now that are favoring, the limiting the usage of sedation for research, absolutely, but for clinical scan as well, for clinical MRI as well. So, they're using trained and full-time child life specialists, who are trained to only do this, make the kids of different age comfortable to undergo their clinical exam and obviously research too. Currently, the system is very rigid and is not supporting the flexibility that it's needed for research. When we need to perform specific MRI, that follow clinical trial protocols. So we will need to think about how we can make that system more flexible, for sure. And also right now, the project have been quite clustered, like within individual research lab, but also within specific population. We do have other research MRI facilities, across MUHC. There's one at the MGH. There are several at the Neuro. That the future is really how we can harmonize all this together to really conduct these great impactful studies, that are describing neurodevelopment across the lifespan and so on. So these are just like a couple of examples of opportunities, and I'm running out of time, and I would love to hear your thoughts after this, but I think you all agree that there's an urgent need that we decide as a community, what are we, or what do we envision for pediatric MRI research, because we are losing ground rapidly when comparing ourselves to other pediatric centers in Canada, but also just in Montreal. And McGill has been well-renowned, has a well-renowned reputation as a world leader in adult neuroscience. So we have to decide if we want to expand this expertise to also pediatric neuroscience in clinical population. And the only place to do this is at the Montreal Children. These are not often inpatient. We're not able to bring those patients outside to other centers within McGill. And otherwise, if we don't react quickly, we might have to just watch the train pass, because it might be leaving without us. And in conclusion, I would like to thank all the lab members that have contributed to the data that I've presented today. So my students and the alumni. I also want to thank my research and clinicians collaborator at the NUHC, and also Jacinthe Barry, who's been the MRI, the platform manager of the MRI at the SIM, who's been trying to navigate these difficulties with me, as well as our current MRI technologists. So thank you for your time.
Thanks a lot, Mary. That was a really nice presentation. I really like the research stuff, and the challenges I think are really important to address. It was a bit traumatizing for me to hear them, but at the same time, I have solidarity, and maybe we'll talk offline about ways maybe we could, like, I had no idea that all this was going on. And so if there's mutual, research needs, maybe there's power in numbers, and we can try to harmonize our calls for help and so on. I'll start with.
And I think if I can just, I think the next step would be to decide exactly as a community if you want to go further and propose a platform. I have been discussing with other researchers, mostly from the pediatric side, to propose for a CFI, but we need, support from leadership, to make this happen, because the complexity here is that because we are on a hospital ground, so we also need strong leadership from the MUHC aspect to push this further.
Yeah. So I just want to touch on some questions that came up in the chat that were a bit more clinically oriented or research oriented. So, so Kaberi asks, and I had the same sort of question. So I didn't know that there was a link between brain structure and function and congenital heart disease. So is it, well, I'll pose your question explicitly. So is the CHD somehow causing the brain injury, or are these two clusters of congenital anomalies that happen to be associated?
So that's a question I often get, especially knowing that the pre-program, development of the heart is also like mediated by or happening at the same time as the development of the brain. It is being currently investigated. However, one of the hypotheses that generally accepted in the community is that as the fetuses is getting older and relying more and more on its own circulation to distribute the substrate to his body and the brain, the lag is becoming more important as the fetus get older. But obviously, this is like, I'm not looking at the genetic aspect right now, but I know that other team, are looking at the genetic component of CHD, but so far there hasn't been a strong link, between the two.
Mm-hmm. Okay, thanks. Susan Bartlett has a comment also in the chat. Very interesting presentation, and that you make a compelling case for the collateral impact on patients and families when we have sterile utilitarian environments. I agree, it was very impactful, the photos, and it's worth rethinking that seriously. And it doesn't need to,
it doesn't need to be too expensive either.
Yeah.
Like I said, like, it's just, we need to make this a priority, the comfort of our patient, and really the think outside the box, especially if we want to perform like long-term follow-up. These are going to be non-sedated, clinical exam, and absolutely, like, we need to think of our young research participant.
So we're at the top of the hour. What I think I'll do is we'll formally end the seminar, and maybe I actually have a couple of extra questions if you have time. And anyone else who has questions are welcome to ask them. Just speak up or chat or whatever. So yeah, my one scientific question at sort of a high programmatic level is, it's interesting that you're using, I also use a lot of imaging to understand early life origins of lung disease. But so as I see what you're doing, I'm thinking, you're interested in neurodevelopment, you're using imaging, you're making links between structure and function. From what you've described in this work, it was largely descriptive. Do you see your program, like, I'm just wondering where the program is headed. Are you hoping to identify things to intervene upon to improve outcomes at the structural level, at the functional level, at the neuropsychology level, do you know what I mean?
Yeah, absolutely. So I think, like, right now, to be honest, post-COVID, like, I'm in the
a fog.
Yeah, I could say that, but also, like, I need to really reconceptualize where the lab is going. But the idea was really to first characterize brain growth trajectories, and also while performing these two cohorts at the same time, like, obviously, like, these are not the same patient, like, it's kind of different time, but like looking at the adolescent and what's remaining, like the enduring deficits, and looking at the young children, if we cannot find regions that could be used exactly as biomarker of intervention effectiveness, as an OT by training, like, focusing on function, focusing on intervention, I would love to be able to demonstrate, that we can change the plasticity of the brain or accelerate, the lag in brain, or minimize the lag in brain development, by some type of intervention. So that was the goal with the baby study. However, that the baby study is dragging, and again, the fifth wave has been dramatic, on the data collection. So we'll see where that would lead. And to be honest, with the current infrastructure, I'm not sure how much I want to continue to do baby stuff, in the current context, so I really need to think about the feasibility, because like I said, the hours and the complexity, and also the uncertainty of getting those data, even though we have the funding, it's not worth the trouble.
You don't need to convince me of this. It's unfortunate. It's really unfortunate. Okay, thanks. That's helpful. There's no other question.
Talking about that CFI, I've been so actually Larry Lenz was on that CFI. I don't know if he talked to you about this, but I think one of the intervention that I see is actually the benefit of exercise, on brain development and on lungs capacity. And I think there's definitively something there, especially in those two populations that we know, even in the preterm, that we know that these have dragging cardiorespiratory dysfunction, later in life, and in the CHD, because of their heart condition, historically they have been, maybe sometimes overprotected by their parent and less engaged in physical activity. And so this is definitively where I wanted to go with those two populations.
Yeah, I mean, I would certainly, on my own behalf, be happy to make a serious attempt at a CFI. I think, yeah, like you said, other institutions are much more in research invested in imaging. One in the US that I'm particularly familiar with, such that you can get really good and good big grants that bring a lot of indirect costs. And so I think we can make a strong case, I hope. Okay, so that's really helpful. Maybe we can talk more offline about, because some of the things you mentioned about the challenges related to MR imaging specifically at the SIM, I don't even think most of the points you raised are not even specific to the research that you're doing. In fact, every one of them, except for the sedation, applies entirely to mine, which is in sort of adults and adolescents. And so, again, just coming back to maybe we should
and to many others, and there are many non-MRI scientists, that have not been able to participate to international clinical trial because they're not able to reliably confirm that they will be able to provide that MRI. So this is really unfortunate. So like I said, we are losing ground. There's an urgent need to do something.
That's great. Yeah. Susan Bartlett raised another comment, which is very true. It's philanthropy. I mean, certainly working in the pediatric space, the little work I've done in the pediatric space, although I just actually got this big grant to do MR imaging in adolescents, but at this other institution, the MUHC, or I guess the Children's Foundation might be another important source.
Yeah.
Sarah Ahmed also expresses thanks for a great presentation.
Yeah, thanks, Sarah, for sure. We are sharing the same department. So yeah, we're within the same department. So we will definitively be talking for sure.
Okay, great. So I guess I'll wrap it up here, but I will be in touch with you because there's some, I think.
Sounds good. And anyone who wants to discuss, please do not hesitate to contact me.
Ciao.
Thank you.